Good afternoon, and welcome to today's webinar. My name is Jim Tsai, and I'm the president of New York Eye and Ear Infirmary of Mount Sinai. We thank you for taking the time to learn about the past, present, and future of New York Eye and Ear. And we have assembled an ophthalmic dream team to share with you some of the latest breakthroughs in ophthalmology that may one day provide us with the ability to not only treat blindness and vision loss, but to restore the gift of sight. This year, New York Eye and Ear proudly celebrates its 200-year anniversary since its founding in 1820 as the first specialty hospital in the United States and remains one of the top ophthalmology hospitals in the nation, ranked 11th this year by U.S. News and World Report. Originally established as a charitable institution for the service of New York City's poor for treating diseases of the eyes, ears, nose, and throat, the infirmary has become a leading clinical research and teaching enterprise. By 1918, New York Eye and Ear had already treated over 1 million patients and established a school of ophthalmology and otolaryngology. Today, New York Eye and Ear remains at the forefront of its specialties in America. New York Eye and Ear is also home to breakthrough clinical research, which has introduced now widely practiced diagnostic and surgical techniques. With a rich heritage and a mission of providing the highest quality patient care, graduate and continuing medical education, scientific research, and community outreach, New York Eye and Ear has built upon its strengths to maintain a leadership position in the fields of ophthalmology, otolaryngology, head and neck surgery, and plastic and reconstructive surgery. Lastly, New York Eye and Ear has been an international leader in restoring the gifts of sight and sound for people of all ages, from infants to senior citizens. As we look forward to our third century of specialty care, we are evaluating how we will need to serve our communities in the future and push forward and innovate with innovative research and exceptional patient care that will set new standards for specialty hospitals. Today's webinar will provide you with a snapshot of a few of our transformational clinical and research projects which will revolutionize the practice of ophthalmology around the world. We hope you enjoyed this showcase by New York Eye and Ear's best and brightest and appreciate your generous support. So I'm going to ask on the screen that a flow code be shown. So you simply open the camera on your phone and scan the code to make a gift. So hopefully you're seeing the flow code right now. And as I mentioned, just simply open the camera on your phone and scan the code to make a gift. And now it's my pleasure to turn the webinar over to one of our co-moderators, Dr. Sandy Mazur, Professor of Ophthalmology and Pharmacological Sciences and Vice Chair for Academic Development and Mentoring in the Department of Ophthalmology at the Icahn School of Medicine at Mount Sinai. Dr. Mazur.
Thank you, Dr. Tsai. We have a superb panel of experts lined up today. We're going to ask each of them to introduce themselves and to talk a little bit about their work here at the New York Eye and Ear. Our first panelist is Dr. Bo Chen. Dr. Chen is an associate professor in the Department of Ophthalmology, but also in the Departments of Cell Developmental and Regenerative Biology and in the Nash Family Department of Neuroscience at the Icahn School of Medicine. Dr. Chen, please.
Yeah, thank you, Dr. Mazur, for the introduction. And it's a great pleasure to present our neuroregeneration research to combat vision loss in retinal degenerative diseases. Retinal degenerative diseases are often age-related chronic conditions. The progression of the disease takes many years, even decades. Take the stages of AMD, age-related macular degeneration, for example. Patients may first experience early signs of vision loss, such as a little blurred vision, and the vision gets worse over time, and At the advanced stage, there can be complete loss of central vision. The loss of the vision is a result of loss of retinal cells over time. Retina, as shown in the bottom graph panel, is a piece of neural tissue in the band of eye. That's where vision starts. If we take a thin slice of the retina and magnify it under microscope, and you can see there are several types of retinal cells. On the outer retina, there are photoreceptor cells, rods and cones. In the inner retina, there are ganglion cells. There are output neurons of the retina. The degeneration of the retinal cells on the outer retina photoreceptor cells underline the pathogenesis of age-related macular degeneration. Glaucoma is another type of leading cause of vision loss, is a result of the degeneration of retinal ganglion cells. If you can think about it, if the loss of the retinal cells can be replenished by generating new retinal cells, the vision can be restored. The question is that even possible? The answer is yes, thanks to the existence of mural glial cells in the retina. Mural glial cells are support cells in the retina. They are sitting in the center of the retina. Mural glial cells are a pool of retinal stem cells. In the presence of environmental insults or genetic defects, the loss of retinal cells can be sensed by mural glial cells, and they multiply and making a lot of daughter cells. And those daughter cells can differentiate into retinal cells to replenish lost retinal neurons and restore vision. And this is a powerful self-repair system. And that is full regeneration capability in lower species, such as zebrafish. However, in the mammalian retina, including lab animals such as mice, all the way up to humans, we lost the regenerative capability in mural glial cells. My lab's research effort is focused on unlocking the regenerative capability of mural glial cells in the mammalian retina to restore vision. Showing in the bottom left is our work in mice. So we show for the first time that we can use gene therapy strategies to unlock and to restore vision in mice. After 2 sequential gene transfer in mural glial cells, we can activate the mural glial cells in the mouse retina and generate new photoreceptor cells. As you can see in these red cells here, they shape like tadpole, and these are new photoreceptor cells, and we can even restore congenital blindness in mice. Our research provides the first proof of a principle that the reactivation of the regeneration in the mammalian retina to restore vision is possible and feasible. The ultimate goal of our research is to turn our lab discoveries in mice to eventually for therapies in humans. There are a lot of steps between, and the next big milestone might be in the non-human primates, monkeys. They share similar features, traits with humans. And our research is one step at a time from the research for mice and all the way up to humans. With that, I'll end my talk. Thanks for your attention.
Thank you very much, Dr. Chen. You're at a very exciting stage for this research. Our next panelist is Dr. Toko Chu. Dr. Chu is the director of the David E. Maris Adaptive Optics Retinal Imaging Laboratory at the New York Eye and Ear, and also associate professor in the Department of Ophthalmology at the Icahn School of Medicine. Dr. Choi?
Thank you, Dr. Mesa. Hi, this is Toko Choi. How's everyone doing today? My research at New Eye and Ear is about non-invasive imaging of human eyes with different retinal diseases. And you may ask, what is retinal imaging? So retinal imaging takes digital pictures of the back of your eyes, and these pictures help your doctor to find certain diseases and check the condition of your eyes. And these pictures can be processed to give a lot of useful information about the health of the neural tissue and the blood vessels on the back of the eyes. And your doctor may recommend certain retinal imaging procedures if you have any systemic conditions or eye diseases such as diabetes, macular degeneration, or glaucoma. So in our lab, we take retinal imaging into the next level by imaging the eye at a cellular level. And our research at NeoEye involves two different high-resolution retinal imaging devices. So the first one, the first imaging device, it's called adaptive optics ophthalmoscope. So to simply put, it's a high-resolution ocular camera. So comparing the traditional imaging devices and this high-resolution ocular camera, it's like comparing the old-fashioned tube TVs to the 4K ultra-high definition TVs. So here on the PowerPoint slides here, I present you a case from 2 years ago. A patient came to our clinic due to a small change of his vision, and none of the regular retinal imaging devices was able to identify what was the problem in the retina. And this patient was then referred to us for high-resolution cellular imaging. And it turned out that he had macular toxicity due to liquid Viagra overdose. And his retina picture is on the right panel on the PowerPoint slides, in which you can see a lot of dark regions indicating individual light-sensitive cells drop out as compared to the one on the left panel, which is from a healthy control. So using this cellular imaging technique, we are able to help both the patient and the doctors to identify the problem in the retina. The second imaging device is it's called optical coherence tomography. And again, to simply put, it's like an ocular CT scan. And the technique allows us to image a very specific type of ocular immune cells on the retina. And on the left here, it's a 1 millimeter cube volume on the back of the eye imaged using this ocular CT scan device. And on the right panel, it's an image showing the surface of this cube, which is the surface of the retina. And each tiny little white dot on this image represents a single immune cell. And as you can see in this movie, we are able to capture the movement of these cells. And these cell movement and the function really reminds me of those iRobot cleaners that I have a very short movie in here. So they both move around on the surface and try to keep the surface clean. And this is how I explain to my patients about the functions of these immune cells. And we are currently applying this imaging approach on patients with diabetic retinopathy and glaucoma to see if we're able to use this type of immune cells as a biomarker for early diagnosis of the diseases. So that's it for my part today, and I will turn it over back to Dr. Maser. Thank you for listening.
Thank you. That was wonderful, Dr. Chu. Our third panelist is Dr. Sean Yanchalev. And Dr. Yanchalev is a professor in the Department of Ophthalmology at the Icahn School of Medicine and is also director of the Ophthalmic Innovation and Technology Program at New York Eye and Ear. Dr. Yanchalev?
Thank you, Dr. Maser, and it's so great to be here with my esteemed colleagues and talk about research and innovation. I occupy myself more with innovation because what is research without innovation if we can't get it to patients? It's kind of like a car without transmission. And I'm here today to really share with you about the milestone that we reached earlier this year. And it's an interesting and very timely milestone. It comes on the 200th bicentennial for New York Eye and Ear. But more importantly, it's a milestone for our department. It's a milestone for ophthalmology in the whole New York area, And it happens to be also a milestone for the United States. And there have been a lot of firsts through the history of ophthalmology at New York Eye and Ear and the New York area with the introduction, for example, of phacoemulsification technology, which is how cataract surgery is done. And we have now the #1 surgical procedure in the world in terms of volume is done in a technology that came out of the New York area. And more recently, we introduced and installed at the New York Eye and Ear the first robotic surgical system with clinical surgical capabilities based on a collaboration that has been in the works for the past 6-7 years. And this is quite pivotal, I think, because robotic surgery is really coming upon us. And this is the first such surgical system for ophthalmic that has the level of precision that makes it relevant to the field of ophthalmology. So again, I would also like to highlight that would not be possible without the leadership of our ophthalmology department and Dr. Tsai, as well as really significant input by the Mount Sinai innovation partners and so many cross-functional groups to really bring this cutting edge technology all the way from Europe that is one of a kind in our country and the world. And I will shut up for a second to play this video now, because I think it really encapsulates that system, and it's much better as a visual than as an audio. So please play the video. Thank you. So as you see, the robotic installation is quite different in the way we do ophthalmic surgery, and it happens to be also a platform technology. And what does platform technology mean? It means that it goes beyond a single application. In this case, this can be impactful for everything from retina surgery, where we need high precision intervention, to cataract surgery, to glaucoma, to cornea. It can really touch every aspect of surgical intervention. And very often I'm asked, well, why is robotic surgery necessary? And in terms of the scale and the impact, probably the best way to illustrate that is if you think about surgical precision of a very good surgeon in ophthalmology, that precision is about 100 microns. The resolution of that precision is about 100 microns of how fine of a discrimination one can have. That surgical system takes us down to about 5 to 10 microns, almost 10 times better. And when it comes to ophthalmology, we know smaller is better and more precise is better as well. So we're very excited. This system is going to go into FDA clinical trials. It's already been approved in Europe. And we're trying to initiate the FDA clinical studies here in the US so that we can lead the way of multiple applications of this high precision microintervention in the ophthalmic field. And that will be a collaborative effort with a lot of the faculty here at New York Eye and Ear and Mount Sinai. And again, this will be something that really, in my mind, illustrates the resilience and the innovation that we have, that in the middle of a pandemic, from ground zero, March and April were tough months in New York, as we all know. We were able to bring that system in and install it virtually because people couldn't travel from the Netherlands, and really get it operational here. So it's very exciting. And this is one aspect of all the innovation that we're doing at the cutting edge and really driving the next wave for the next centennial. Thank you very much.
Thank you, Diane. So this has been very exciting so far, and I now want to turn over the program to Dr. Paul Sidoti, my co-moderator, to introduce the remaining panelists.
Thank you, Dr. Mazur, and good afternoon, everyone. Our next panelist is Dr. Richard Rosen. Dr. Rosen is the Pierce Distinguished Chair in Ophthalmology, Deputy Chair for Clinical Affairs, Vice Chair for Ophthalmology Research, Surgeon Director, and Retinal Service Chief at New York Eye and Ear, and Professor in the Department of Ophthalmology at the Icahn School of Medicine.
Thank you, Dr. Sidoti. Great. So I'm going to talk about quantitative assessment of the retinal blood vessels. So the eye is the one place where we can directly visualize the central nervous system and its capillaries. By looking through the pupil, we're able to see the optic nerve, which is part of the brain, and we can see all of the blood vessels. With optical coherence tomography angiography, a new non-invasive technique, we're able to visualize the retinal vessels without the use of any external contrast agent. We can break down the blood vessels into multiple layers, which is something we've never been able to do before. And it allows us to distinguish changes between a normal and a diabetic eye. So here you can see in a patient with diabetic retinopathy, there are small microaneurysms, there's loss of capillaries. And when you compare this to a normal eye, you can see that the diabetic eye has lost, it's somewhat threadbare in its amount of capillaries. There's small little bulbs there, which you can appreciate as being abnormal blood vessels that have closed off compared to this healthy eye, which you're seeing here on the right. So as you go through the different layers, you can appreciate how the disease has really ravaged through the eye. In our lab, we've actually developed a number of quantitative measures, looking at the density of blood vessels, looking at the blood oxygen supply, changes in the structure, loss of blood vessels, changes in the overall appearance and in the risk for progression. We've actually added this to the clinical measures to try to see how diabetic retinopathy and glaucoma progress in a vascular manner. So to this we've added adaptive optics angiography that Dr. Chui showed you, and basically with OCT angiography, we capture individual frames of a movie. So sometimes certain vessels will appear and sometimes will disappear. And we've used this to study sickle cell disease. Sickle cell disease is the most common inherited blood disease, and basically it involves abnormally shaped blood vessels, which include the small capillaries. You can actually see that there's intermittent flow in this central area within the retina. And you can, with the adaptive optics, we're actually able to see individual red blood cells as they track through these capillaries and see that the changes that occur. This is actually a single abnormally shaped cell in capillary in a patient's eye. We've taken this one step further to try to develop a means of measurement of therapeutic value of certain things. And here's a patient who's been treated pre-treatment and post-treatment, and you can see that with treatment, they've actually been able to decrease the intermittent flow in this patient's eye. When we looked at it closer with adaptive optics, we're actually able to appreciate what kinds of changes occur. So we have areas where the blood is blocked and sometimes it's restored. Other areas where the capillary is completely closed off and it's restored. In other areas, we look and we see that their pre and post treatment. There may be restoration. There may also be areas that are regress. And in fact, this treatment is not perfect. So in some cases, the disease still continues. So in summary, the high resolution imaging that we've been involved in developing shows us many new aspects of disease that clinicians really were not able to access in patients, and will help lead us into the next generation of therapy for some of these very important diseases. I want to thank you for your attention.
That's really fascinating work, Dr. Rosen. Thank you. Our fifth panelist today is Dr. Louis Pasquale. Dr. Pasquale is a professor in the Department of Ophthalmology at the Icahn School of Medicine, site chair for ophthalmology at Mount Sinai Hospital, director of the Eye and Vision Research Institute at Mount Sinai and New York Eye and Ear, and deputy chair for ophthalmology research for the Mount Sinai Health System.
Thank you, Dr. Sidoti. People often ask, what is artificial intelligence? And we know that humans learn from experience. Computers can learn from prior data. In fact, other researchers have shown that you could train a computer to diagnose glaucoma from a simple optic nerve photograph and can do it as good as or better than a glaucoma expert. I have a different vision for how artificial intelligence can help, and that is to understand the upstream factors that contribute to the development of primary open-angle glaucoma. Primary open-angle glaucoma is a disease of the optic nerve, and the optic nerve is like a telephone cable that connects the eye to the brain, and in glaucoma, there's a premature deterioration of the fibers in the cable. It is projected by the year 2040 that 114 million people globally will have this disease. So what do I mean by preclinical phase? How are we going to find these upstream factors? Well, we could take any disease and put it out in a timeline. For glaucoma, we presume you start out with a normal, healthy optic nerve. Then something happens, and we don't know what that something is, but the first clinical signs of the disease is development of structural damage to the optic nerve. And as the disease progresses, there is vision loss that can ultimately lead to blindness. So what we're trying to do is to find out what's going on during that preclinical phase of the disease. And what we've been doing is following large cohorts of health professionals over decades, collecting data about when they developed glaucoma. And along the way, we ask them what they've been eating, what they've been drinking, how much exercise they've been doing, what other medications they're taking. Also, very early on, we did everything from take toenail samples to DNA specimens from these folks. And what I can say very briefly is what I've learned is that primary open-angle glaucoma is not only secondary to one thing, it's secondary to many things. And it's a disease with a strong genetic component. And this is what we're trying to use artificial intelligence to tease out. What is this complex web of pathophysiology around this disease? In glaucoma, there are many different patterns of damage that the optic nerve can undergo. You can look up at the top left and see an optic nerve damaged with a hemorrhage on its nerve head. And associated with this is early paracentral visual field loss. What we're finding is that the patterns of damage that develop in glaucoma are secondary to many mechanisms, including vascular dysregulation. And you saw the beautiful slides of our ability to image vascular pathology. And I'm very excited by that work by my colleagues. But there are other mechanisms also: estrogen deficiency, mitochondrial dysfunction, and oxidative stress. And so what we know is that the different patterns of damage to the optic nerve underlie different patterns of vision loss. And what my colleagues have developed is an artificial intelligence algorithm to objectively identify the different patterns of visual field loss that occur in glaucoma. So we've collected over 2,000 cases of new onset primary open-angle glaucoma, and we asked an artificial intelligence algorithm to please learn the different patterns of visual field loss that our patients are undergoing. And you see the different patterns ranging from AT1, which stands for archetype 1, which is normal, all the way through 16 different patterns of loss. Thank you. And then, so what this artificial intelligence algorithm can do is to take a visual field, such as this one here where it says TD probability, where there's some damage. And basically the algorithm is recognizing there's 3 different patterns of loss in this patient. There's a normal pattern, there's a pattern called AT5, where there's damage near the nose. And then there's another pattern called AT16, where there's sweeping damage across the inferior visual field. So what are some of the insights that we've gotten so far from you taking this approach? And this is basic stuff. Number one, we've learned that paracentral loss is common in this disease. And so that's AT14. In other words, there's a good percentage of glaucoma patients who present with damage right in the center of their vision, akin to macular degeneration. You could read any textbook on glaucoma, and they don't say that this happens. They say that glaucoma is a disease that affects the peripheral vision, and then it gangs up on the central vision at the end. But it turns out a subset of patients will get damage early near the center of their vision. Number two, the pattern of loss that happens in one eye tends to happen in the other eye. So unfortunately, if a patient has a strong component of archetype 14, AT14 in one eye and the other eye is normal, our data is telling us that it's likely if the other eye gets damaged, it's also going to get damaged in the center of the vision. And that is concerning, and that's something we have to stop. Number three is we have African American patients in our cohorts, and what is really dramatic is that we find that they're most predisposed to the following patterns. And if you can point to these, AT6 and AT6, yeah, that's a bad pattern. That means that you've lost a lot of visual field early on in your disease. AT13 and AT8. So you're either losing half of the upper part of your field, half of the lower field, or half of the entire field. This suggests that there's a different biology operative in patients of African descent. We have to identify these patients early, and we need to get on our high horse to figure out what's going on with these patients. So where do we go from here? Well, first we start to look at what we want to do is find out what are the determinants of each of the different visual field subtypes in glaucoma. We're in a pretty good position to do that because we collected blood on our participants long before they developed any of these diseases. We took that blood, we isolated the DNA, and we stored it away to a time, which is the present, where we could take a very small sample of that DNA, not even use up their whole sample, and genotype them at tens of millions of locations throughout the genome to find out what are the genetic determinants for each of these subtypes. We also took the serum component from their blood and banked it away for a day where we could analyze thousands of metabolites all at once from a very small sample of their specimen. This is called metabolomics. And we're hoping by using genomics and metabolomics that we're going to be able to figure out what's causing each of these different subtypes of the disease. Also, we're hopeful that because these specimens were collected during the preclinical phase of the disease, we'll get some insights in how to prevent glaucoma from happening in the first place. Thank you for your attention.
That's really great work. Thank you, Dr. Pasquale. And our final panelist is Dr. Douglas Frederick. Dr. Frederick is System Chief of Pediatric Ophthalmology and Strabismus for the Mount Sinai Health System and Professor of Ophthalmology, Pediatrics, and Medical Education at the Icahn School of Medicine.
Thank you, Dr. Sidoti, and thanks to each of you for tuning in today and participating in this webinar. I'd like to talk a little bit about the third realm within which New York Eye and Ear truly excels. We've already heard that New York Eye and Ear really is the best place to receive care, whether you come from New York City, anywhere in the United States, or internationally. We've also learned that New York Eye and Ear excels in research, which you've heard from the previous talks. But for 200 years, New York Eye and Ear has also been the best place to obtain education, to learn how to become an ophthalmologist. And I want to spend a minute talking about what that path entails. So each year, there are about 2 million young men and women who obtain their bachelor's degree at universities and colleges around the country. Of those 2 million, 17,000 choose to pursue a career in medical, to become a physician. Of those 17,000 medical school graduates each year, only 650 are wise enough and smart enough to choose a career in ophthalmology. Every training program looks at those 650 applicants to determine what would be best for their program. Who would take advantage of what our training program has to offer? Of those 650 applicants, we choose just 10. 10 residents who will spend 4 years with learning how to become the best clinicians, the best researchers, the best educators. And of those 10 residents a year, after their 4 years of training, they will join the 24,000 ophthalmologists who are currently practicing in the United States. And at each step of the way, whether it's undergraduate medical education, graduate medical education, or continuing medical education, New York Eye and Ear has really been a premier of this education, this opportunity to continue our personal journeys in professional development so that we can become the physicians who you want to care for your eyes, who you want to come to take care of your loved ones. I want to talk about how we participate in the education at every part of this path. As a medical student, medical spend anywhere between 4 and 6 years learning to become physicians. But from the very first year, we have faculty members who are working with these 150 Icahn School of Medicine and Mount Sinai medical students each week from 4 to 6 hours a day, teaching them how to become not just good physicians, but also to show them the opportunities that exist in ophthalmology. The East Harlem Health Outreach Project is the opportunity for medical students to work with residents and faculty members in the Department of Ophthalmology to provide care for a population here in the Upper East Side in East Harlem, patients who wouldn't get care otherwise, who can get provided by medical students supervised by members of the faculty as well as trainees within the Department of Ophthalmology. After medical school, we spend our focus training residents. Residents spend 4 years learning to become ophthalmologists. They take care of about 15,000 patients during that 4 years time period. They receive over 500 hours of didactic education. They perform hundreds of surgeries and thousands of procedures during that time. It's an intensive time period, but we make extra special care to make sure that before they touch anybody, before they do any surgery, they're prepared. And we have the world's best simulation center, the Buxton Microsurgery Suite, where where residents can use simulation technologies, practice their skills so that before they take care of a patient, they have the ability to provide that care in a safe and effective environment. And then finally, after they finish their training in residency or fellowship, they join the community of ophthalmologists. Again, 24,000 people providing care around them. And each year, New York Eye and Ear, we have over 300 hours education that's available on various platforms to ophthalmologists in practice, whether it's in grants, whether it's in our courses that we provide 2 or 3 times a year to ophthalmologists, where we gather the best educators, the scientists from around the world to disseminate that information to those who want to come to New York to learn. The virtual platform that you're learning on today is very well suited for this form. We all want to get together. We all want to learn in person, but we know that using this platform, we can be very effective at transmitting new information, very effective at allowing ophthalmologists to continue to learn, to continue to grow, and to continue to provide care for patients wherever they may be. Thank you very much for learning New York Eye and Ear.
Thank you, Dr. Frederick. I think that this is an extraordinary presentation, opportunity to see the whole range of our faculty in terms of research and teaching and clinical care. I'd like to now ask you to do a little deeper dive in some of the research that was presented. So we'll do it in order of the presentation, and therefore I'll start with Dr. Chen. May I ask you the following? What are the challenges to translating your findings in the lab to therapies in patients?
Yeah, thank you, Dr. Mason. Yeah, I just unmuted myself. Being able to translate, to put what we find, the research findings in the lab, in animal models, able to actually turn it into treatment in humans is the ultimate goal and the driving force for our research day in and day out. So neuroregeneration is to generate new retinal cells to replenish lost retinal cells and restore vision. And I think there are a lot of steps between our research to the ultimate treatment. And the major challenges I can think of, there is at least 3 of them. So one is to improve the regeneration efficiency. In order to turn the discovery into treatment, we need to generate enough number of retinal cells to be able to restore the lost cells to benefit the vision. And we're working on the different strategies and both genetic and molecular way to generate more retinal neurons, photoreceptor cells per se, for the improvement of the regeneration efficiency. And secondly, because of the retinal degenerative diseases, it's not just affecting photoreceptor cells, such as AMD, macular degeneration. It also affects ganglion cells, for example, glaucoma and diabetic retinopathy. So the second challenge is, are we be able to generate retinal ganglion cells, for example? And that is the second challenge we're working on now. And the third challenge is, before putting the basic science research into human trials, there's a necessary step to test that in large animal models. And the best large animal models would be non-human primates, because humans and monkeys share a lot of genetic traits. For the retina, we share very excellent vision with non-human primates. Also, the retinal structure and physiology, the human retina and the monkey retinas are very similar. So I would think if we can test and make that happen, the regeneration, restore vision in the monkey retina and show the efficacy and safety in the monkeys, and there were a lot of in the way to make a lot of improvements towards the final goal of human therapy. Yeah, thank you.
Thank you, Dr. Chen. This is very exciting to hear what the next steps will have to be. Definitely worth doing. So let me move on now to Dr. Toko Choi and ask you, Dr. Choi, what are the advantages of viewing living retinal cells?
Thank you, Dr. Mazer. So we need high resolution cellular imaging to detect the most subtle changes in the eye. So that's why we need to see this kind of, to do this kind of in vivo high resolution cellular imaging, so that we could save sight by making more accurate diagnosis and initiating earlier treatment. So the enhanced views or the high resolution views of the eye and its structure really help near clinicians to make earlier, more accurate diagnosis, as well as monitoring cellular effects of the treatment.
Okay, then a second follow-up question is, how safe are the light levels that you use during ophthalmic imaging?
I see. Okay. So yeah, it is well known that intense light source can be very harmful to the eye. And this also applies to the light sources that we use in the clinic in the eye imaging devices. So the question is, to what extent does the light we use to examine the eye put the eye itself at risk? So the extent of the risk, it's actually related to 2 major factors. So the first one is the light source that we use for imaging. The second one is the time factors, which means that how long do we expose the eye to the light source. So the first one, different types of light sources have different safety guidelines provided by the American National Standards Institute. This is an organization provides guidelines about the best way in which we can safely image the eye. And all the imaging devices we use at New Eye Near pass these safety guidelines. And the second factor, which is the time factor, the shorter the exposure, the smaller the risk. So time is a very critical factor in determining the safety. And at New Eye Near, we do not put our patients through any unnecessary imaging procedures. But in case if we really need to perform any retinal imaging procedures, we keep the imaging times as short as possible. So it's pretty safe.
Thank you very much. And this sounds like it's going to continue to really pay off in terms of the kinds of information. So now moving on to Dr. Sean Ianchulev, I have to ask you, your presentation was really interesting, and I was wondering if you can tell us how can robotic eye surgery deliver better care and outcomes than our superb ophthalmologists?
Thank you, Dr. Mazer. This is a great question, and actually the answer is in the presentations of my colleagues. In fact, as you see, Dr. Chui, Dr. Rosen are now able to image at the very cellular level. Dr. Bo Chen can actually deliver cells and stem cells. And we're talking micron level entities here, where we're looking at the micron level. Currently, our precision as surgeons is at the millimeter or small fraction of that. So when we have to go down to cellular therapies, where we have to go down and impacting structures that are micron level precision, we have to use some sort of assistance because our manual precision can get us to the millimeter level or maybe a little bit below that, but it cannot get us to the micron level. And as I mentioned today, I think the good surgeons and all of us here at the New York Eye Near in Mount Sinai, I think are at the 100 micron superb level of precision. And even with that, we're orders of magnitude above where we need to be in order to drive the gene therapy, the stem cell therapies. And again, technology comes together in a very, very fluidly, and it comes right when you need it. And I think as we're getting to the cellular therapeutics and we're going into this level of precision where we need it, we need that robotic surgical extension to get us there. And it's coming together very timely. Just like, for example, when we were driving the next generation of AMD therapies, and I was involved in the design and the clinical programs for Lucentis, which is the one major therapeutic now. When we started those programs, we didn't have OCT, and OCT was not used. And now it's used as part of the paradigm for treating these diseases. And it came right at the nick of time when we needed it, as we were opening up another therapeutic frontier. So I think robotics is here. It's very complicated. It takes a lot of effort. It's something that took almost 10 years of working with the company. And again, more companies are rushing into that space. And one of the things that is really great about this technology is that it can empower every field or subfield in ophthalmology and all that research to really make it relevant and translational and bring it to patients.
Thank you. Thank you so much. This is superb, and so we're so lucky that you were able to bring this robotic surgery to New York Eye and Near as a first place.
Yes, it's the newest resident of New York.
Thank you. And
Thank you.
now I will pass on to Dr. Sidoti.
Thank you, Dr. Mazer. Thanks to all of our speakers. I have next questions for Dr. Rosen. Dr. Rosen, what future advances do you foresee in ocular imaging technology, and how might they be used to advance the clinical care of our patients?
Thank you, Paul. So we've seen tremendous advances over the last number of years in terms of computer technology, in terms of the speed of the computers, in terms of the ability of the detectors to be more sensitive. The technologies that I showed today are based on a lot of these advances, and they continue to move forward. So as we move to faster systems where we can get wider views in a single view, I think that it will make it easier for clinicians to adopt these technologies into their everyday use. Some of the things that I showed go back about 7 years, and currently I think that the next generation is on the table, and it will about to be released within the next couple of years that will allow us to see the entire retina at that level of precision. And with that, we were able to add the kind of quantitative metrics that we need in order to judge treatments much earlier. So we can detect earlier, which will mean that we will have better treatment options for patients. If we can pick up the earliest changes in diabetic retinopathy before they cause any loss of vision and treat them effectively, I think that this will improve the lives of so many people who are struck with this disease.
Great, thanks, Richard. Thanks for those insights. Next question is for Dr. Pasquale. Lou, how do you foresee artificial intelligence leading to better diagnosis and treatment for our glaucoma patients?
Thanks, Paul, for that question. Great question. And the reason why I went into glaucoma in the first place is because I thought we needed better treatments, and better treatments really start with a better understanding of the disease. And, when you think about it, the way we treat glaucoma now is by lowering intraocular pressure, either with medicines, lasers, or surgery. We never really give the individual patients concerns when we think about a treatment plan. We kind of treat every patient the same. And I think that every patient's not the same. That's what my research is telling me. And I tried to figure this out on my own without artificial intelligence. I even gave a lecture about how I thought glaucoma was stratified out. But what I was learning was that patients are a little bit, 10% from column A, 50% from column B, and another 45% from column C. And I couldn't figure out which components the patients had. And by relying on visual fields, I think that we could gain some insights into what combinations of factors are contributing to each individual patient's disease. And then once we can do that, then I think we can hand tailor a treatment that would be appropriate for them. I really think that each one of those patterns that I showed, they're telling a different tale of woe about how that patient got to where they were. And by understanding how they got to where they were, we'll come up with better treatments for those patients.
Great, Lou. Thank you. Thanks for those insights. Really looking forward to providing better care to our patients through all this work. My final question is for Dr. Frederick. Doug, how has a great training program like New York Eye better through integration into that program?
Great. Thank you, Paul. New York Eye and Ear has always been a fantastic place to learn how to become an ophthalmologist, but the extension of the program will really provide many more opportunities for our residents. They allow them to go to Elmhurst Hospital in the Queens, where they'll be able to take care of the most patient population you can imagine. This is a hospital, again, where many of our residents went to deepest, darkest days of COVID to volunteer their services, not just as ophthalmologists, but as physicians physicians taking care of patients in their most dire need, helping colleagues. So they'll go to Elmhurst Hospital. They'll go to the Bronx, to the VA hospital, where they have the opportunity to another unique patient population, and people who dedicated part of their lives to serving our country, a very special and most deserving population that they wouldn't have been worked with otherwise had we not expanded or integrated the programs. And finally, they'll be able to spend more time at Mount Sinai School of Medicine, the Icahn School of Medicine at Mount Sinai, where they'll have the opportunity to basic researchers such as Dr. Chen, where they'll be able to work with educators in the School of Medicine, how to become better educators themselves. They'll be able to participate in global health. We'll be able to go out to help other physicians learn how to provide care when they're under-resourced, challenged with incredible burdens of disease, to learn from those doctors as well as to share new knowledge with them. So really, this will provide more opportunity so that when they train in New York Eye and Ear, no matter what they want to do or where they want to go, they'll be very well prepared to take care of patients in any environment, patients with the greatest need. Thank you.
Great, thank you, Doug. Now turn over the mic over to Dr. Tsai for his closing remarks.
Thank you, Dr. Sidoti and Mazer, for co-moderating what I think has been a very exciting webinar detailing innovations and breakthroughs in both research and education, which I think have impacted patient care and will continue to enhance the level of patient treatments available. I want to thank again Dr. Chen for talking about the possibilities of neuroregeneration, which may have potential treatments for diseases such as blinding diseases such as retinitis pigmentosa, macular degeneration, and glaucoma. I want to thank Dr. Chui for telling us about all the exciting advances in vivo cellular imaging, especially of the retina, and really just what her research is opening up in terms of our understanding of retinal diseases. I want to thank Dr. Yanchalev for really showing us what the possibilities can be in New York Eye and Ear's third century of service to the community with microsurgical robot technology. This technology is the first in the United States, third in the world, and once again demonstrates New York Eye and Ear's leadership in advancing ophthalmology and vision science. I also want to thank Dr. Richard Rosen for really giving us concrete examples of where this in vivo imaging is making an impact on patients with diabetes, diabetic retinopathy, patients with sickle cell retinal disease. I want to thank Dr. Lou Pasquale for really advancing the field of artificial intelligence and glaucoma and demonstrating to us just all the advantages of using AI in helping to diagnose as well as help guide our treatment decisions in glaucoma and potentially other diseases. And finally, Dr. Frederick, for really detailing what New York Eye and Ear has stood for over 200 centuries, transferring the knowledge that is obtained in ophthalmology and vision science and training tomorrow's leaders in practicing ophthalmology. I also want to thank Melanie Barton-Wunsch and the entire development office, the special events office and the AV team for putting on this webinar. I want to reference Tom O'Brien in the Office of Development. Please direct any additional questions to Tom. If you have any questions to some of your questions, Tom will be the person to really correspond with our scientists and researchers and educators here who spoke today to really get you the answers that you need. And in terms of the flow code on the screen, please take a picture, and your support is greatly appreciated to continue to advance the innovation and breakthroughs that we've presented today. Now, I want to also mention that this webinar will be recorded and shared with all of you. So I want to thank all of you for watching and attending. And we want to continue to be a resource to those in the community who are striving to learn more about advances in ophthalmology and vision science. Thank you all.